Good morning. Chris Ohl here, Wake Forest Baptist Health, Infectious Diseases. The format this morning for our briefing is a little different than what we have done in the past. As you may know, we solicited questions from our viewers, and we got a really great response. And we don't simply have time to address everybody's questions. So the ones that we've talked about in our briefings, particularly last week's briefing, we kind of put on hold for now so we could get to some questions that really hadn't been asked yet. And so if you have a question that's not addressed, and if it involves travel or things such as that, get-togethers and vacation time. We talked about that at length last week, so pull up last week's briefing off of Facebook Live, and then if your question isn't addressed, resend it in, because I think we'll have another question and answer session next week, because I like the format. So with that, we're just going to go ahead and dive in. And the first question posed to us is from Christy. And she asks, what are your thoughts on preschools reopening? Do you think it causes more harm to have their socialization limited in a preschool setting than just continuing to be home with their family? So this is a great question, and I think it even applies some now to schools a bit. And so first, let's look at some science. So just this week, there was some information that was put out talking about how infectious is actually a child compared to adults. And this was looked at in household settings. So in a household setting is about as high as you can get for transmission risk. And in these settings, it depended on age. And the age cutoff they looked at was age 10. Below age 10, the risk of transmission from a child to other family members in a household who were in the middle of being quarantined together was about 10 to 25%. And then for children from 10 to 17, it goes up, and there it was roughly about 30 to 40%. If you look at adults in the same household who are living together, it's almost 100% when you're quarantined together in these small quarters. So the younger the child, the less infectious they are. And so daycare centers are less of a problem than households or other areas. So I think daycare centers can be open, and I think they can be done. It can be done so safely. There's CDC guidance for daycare centers on what to do and how to do to be as safe as possible, and I think the guidance is sound. So daycare centers have been open, a lot of them, since the beginning, because parents have had to have places for their children. So if you have essential workers, then you need a place to have your child cared for. So far, so good. We've had a few very small clusters of outbreaks in daycare centers here in North Carolina. Usually they're very limited in number, and the mitigation for what to do with it is been fairly simple, and the clusters haven't extended out. So I think that daycare centers are performing very well here in the area. And yes, there will be cases from time to time, just like families have cases from time to time. But so far, I haven't been seeing anything that's really worrisome. So suggestions, if you're thinking about putting a child in daycare, is visit the daycare center and see what they're doing. And that's probably going to be a virtual visit, because most daycare centers are trying to limit access, which is a good thing. And ask questions about how they might be following guidance, what they're doing to limit risk. Are parents allowed in the daycare center? Not allowed in? Most places now have gone to curbside handoffs for children, which I think is a great idea. And to tell you the truth, the question about is limited socialization versus the small risk of being in daycare is a personal decision for you and your family. But socialization, I think, is important for young children. And particularly as they get closer to kindergarten age. I think that I think you can have a child safely in daycare, and I think some of the socialization benefits would outweigh. Now, if the characteristics of COVID and our epidemiology change, I'll be the first person to say, hey, now's the time to start to rethink that. But right now, I would feel comfortable putting a child in daycare. So Helena asks us, can you tell us more about rates of transmission from kids, especially preschool age? Well, I think I just mentioned that. It does happen, but it's not as common. Are they turning out to be vectors for parents or older kids? Not so much. So I mentioned the household risk of transmission, and that study was actually done in South Korea, where the houses are smaller and a lot of people live in apartment situations, and household transmission is even greater than it is here in the U.S. So for children under the age of 10, it's not real high, but it does happen, but it's not real high. When children do get COVID, their symptoms for the most part are milder. In fact, there's a higher proportion of them are totally asymptomatic, and they don't shed as much virus as adults do. Now it changes some as you get older. Obviously, high school kids behave a little bit more like adults in their transmissions, So we're learning more. I think we still have more information to gather about this. But unlike flu, where kids are the petri plates who go to school and then pick up the virus and bring it home, that doesn't seem to be quite that way for COVID. In fact, it's the other way around. It's adults giving it to kids. Right now, what age group is the main driving force for driving infections and clusters? Is adults between the ages of 10 and 35. And it's because that age group tends to not follow guidance about mask wearing, gathering in clusters of people, and socialization closer than 6 feet. So it's a pretty social group of people, and it's these social situations where people are getting infected. In fact, I can think of 4 clusters of people, of cluster outbreaks involving families visiting either in the mountains or the beach, where you get large family groups together from different households. And the index case in the 4 I'm thinking of right now was all a person between the ages of 10 and 30 who came down to hang out with parents and other family members at the beach house. So that's the one that's driving. So Laura asks, is my newborn baby is exclusively breastfeeding? How are babies affected by the coronavirus? Will the mother make antibodies in her breast milk if she and her baby are exposed, just like any other virus? Is the virus milder in babies and very young children? So yeah, it is a lot milder actually in neonates and newborn babies. Don't really seem to be getting this. There are some cases, but it's pretty uncommon, and that includes here at Brenner's Children's Hospital, and we've had very, very few babies who were positive below the age of 1. And in fact, a large study was just published this week in the Journal of the American Medical Association of looking at newborns who were born and had COVID positive mothers. And this large registry study, there were no newborns who picked up COVID from their mom in this, and this was done here in the U.S. And that completely now has changed guidance from the American Academy of Pediatrics and from our neonatal and intensive units, and now we encourage newborn babies to room with their mother even if they're COVID positive, and to breastfeed and have those very early associations and contact that's so important for mother-child bonding. So I think very quickly you're going to be seeing birthing centers across the U.S. pick up on this policy. So that's all real good news. There are, if mom was COVID positive in the past and has antibodies, particularly a certain class called IgG antibodies, those will be excreted in breast milk, just like antibodies do from other viruses. So that's also good news too. And perhaps one of the reasons why neonates from COVID-positive mothers don't seem to be getting it. Can COVID be, a little corollary question here, I'll just bring up on my own. Can COVID be transmitted from mother to baby in the womb, congenitally, so before the baby is born? Doesn't look like it. There's been maybe 2 cases in the world that have been looked at from this, and perhaps those babies were actually affected after birth, but it doesn't look like it. So unlike other viral infections that pregnant women can get where the baby might be afflicted, COVID does not appear to be one of those. Beth asks, we want to help with our new grandchild who will be born in November. We are retired and are trying to figure out how to make this safe for us all. How safe can we make this, and what should we consider? So I get asked this question a lot, and maybe that just reflects I have a lot of friends who are grandparents now. There are things you can do to help out with the grandchild. So, and let's go and talk about some of these. So one of these involves the bubble concept, okay? And this particularly pertains for grandparents who live in the same geographic area as the children and would be frequent visitors. So what is a bubble? And this is talked a lot about in the media. A bubble is when you have a cohort of people, a group of people, usually a family or very close friends, and they decide together to be in a bubble and to not have a lot of activity outside of that bubble. So that would mean that if you as grandparents are in the bubble with the family, that would mean you as grandparents would not be going out and spending a lot of time with other people, particularly in group settings. You would be limiting your exposures in the higher risk areas, and such as big neighborhood get-togethers, weddings, funerals, places where a lot of people get together. And that doesn't mean you won't go to the grocery store. It doesn't mean you won't go to the pharmacy. You can still do those things. It also means that you as grandparents would be kind of signing a pact with that family to be masked when you go out, and to be personally distant when you go out. And thus you then entered the bubble of that family. And when you do that, that means you have the same risks as that family. And then and you become like a household member in a way, even though you might live apart. And then it's a lot safer for the family within that bubble. So other things that you can do, let's say you're a grandparent, but you don't live in the geographic area, so you're not getting together all the time, which means that your bubble is separate from the bubble with the grandchild in it. Then that would mean that for the time before the visit, you would try to quarantine yourself to limit exposures to other areas. And then when you go to make the visit, if you have to travel by car rather than plane if you can. And if you have to take transportation, rent a car rather than public transport. And then once you get into the home with the baby for the visit, you stay there for the most part, and you don't go out and do other things. And you would try to be personally distant from the grandchild, and to stay masked. And if you have contact, say you're going to diaper and help with nap time for the baby, that would mean hand sanitizing before contact with the baby. Keep your mask on, and I think that you can visit safely. So there are ways to do it. And there are some suggestions on the CDC website too, including some of the things that we've talked about. I think we still need to have some of these human contacts and family contacts that are still important to us, and it just means thinking them out a little bit. And if you have questions, you can talk with the baby's pediatrician as well. So Pat asked a very good question about visitation in nursing facilities, especially for dementia patients who do not understand televisits. What guidelines would you recommend? Are outdoor visits 6 feet apart with masks safe? This is really, I think, one of the most tragic things about this COVID outbreak, actually. Is our elderly parents in nursing facilities, and that because nursing facilities really have had to lock themselves down to keep these vulnerable persons from getting COVID, it basically means no visitation. And for those with dementia or other cognitive impairments or visual impairments, virtual visits are very hard. It's not just like how we would do it. And so what can you do? Well, first you would need to work with the facility a little bit, and all facilities are a little bit different. And if they had the ability to have the member leave the facility for a short time period to an area like a park or a very close by area outside, everyone stayed masked and 6 feet apart, technically it would be okay. But I don't know how many facilities are going to permit that. I think a lot would be nervous. And a lot of retirement communities even are nervous about this. And hang on a minute. So I think that I think might have to just kind of deal with what the rules are, and those rules are there for protection of the many, and unfortunately for some of the few, it's not optimal. Now, if the person's not in a nursing facility or not in a retirement home, and say they're being cared for at home, then it's just the common sense things we've talked about before. If they're in your own household, it means you're all in the same bubble. So it means everyone in the bubble needs to behave safely, particularly in their out of bubble activities. And then if you're going to visit a home where there's an elderly person, yes, you do it outside under the tree, the shady tree, and be 6 feet apart and use a mask. But in facilities, unfortunately, I think a lot of the rules are going to get in the way. Susan asks, is it true that the test will pick up and be positive for anything in the coronavirus family, such as colds or flu? So there's two kinds of tests that we have. Let's say there's three kinds of tests. There's the PCR test, which looks for the RNA, the nucleic acid of the coronavirus. These are pretty specific. They don't really pick up other colds. They don't pick up the flu. They're pretty specific just to the SARS-CoV-2 virus, which causes COVID. antigen tests have a little bit of cross-reactivity, but for the most part, they're also pretty specific. What is an antigen test? These are tests that have just come out in the last few weeks, and you're going to be seeing a lot more of them in the next month or so, that actually look for pieces of the virus protein rather than for the messenger RNA. They're not quite as sensitive as the RNA test, the PCR test, but for most settings they're probably good enough. But they can be done quicker. They take about 20 minutes, and as the machines start to get out there into the world, well, we're going to see some of these being used as point-of-care tests, just like a strep test or a flu test that might be done in your doctor's office. And these tests are also pretty specific, and they won't pick up other colds and flus. Now, the antibody tests. Well, the last I looked, there were about 150 different antibody tests out there. And those actually measure our immune response, the antibodies that we make to the virus. And those tell you if you've been infected in the past. But they don't tell you much about your state of infection or non-infection at that moment. Some of those tests have problems with cross-reactivity with colds due to the other coronaviruses, and they're not very specific. So when you're testing, if you're going to get an antibody test for some reason, it's probably best to do so as part of a research study so we can use that information to help define what's going on with who's got the virus, where the virus is, what the risk factors for the virus are, rather than to try to use it for personal decisions for you, at least at this moment. And then if you are going to get an antibody test, you should ask the person who is ordering the test what the quote specificity is for other coronaviruses. The good ones are pretty specific. The ones that aren't so good can pick up other viruses. So Marcia asked, what are our thoughts about antibodies? I'm hearing reports that antibodies are not staying in a person's immune system very long. Yeah, that came out, was it last week, I think? It had a little bit of media. And people were saying, oh, that's worrisome. And there were a lot of furrowed brows. And because the obvious implications, if antibodies don't stick around a while, for more than a while after infection, that a person will lose their immunity. And that puts into question the whole herd concept. And it also puts in the into concern about vaccination. So regarding vaccination, if the antibodies don't stay around quite as long, we can get around that by having the vaccine every year, just like we do for a flu shot. So, and how long the antibody lasts as far as developing immunity and what that means for immunity in the future, we don't really know yet. And so there are a lot of different viral infections where antibodies start to go down with time. In fact, that's normal. And so it doesn't surprise me that that would be true for COVID's antibodies also. The thing is, with immunity, is it's a lot more complex than just having an antibody or not. Because there are other things that can make us, that our immune systems use to fight viruses. One of them are called T cells. And T cells are integral for our immune response to viruses. And there is data that T cells may actually recognize coronavirus once a person's been exposed once for a longer period of time than the antibodies. So that's good news. And then the other aspect is we have something called memory B cells that are involved with making antibody response. So what's a memory B cell? A memory B cell is a cell that hangs out after a person's been exposed once and remembers how to recognize and make antibodies very quickly. So let's see the scenario. So let's say you were exposed to COVID. You develop a lot of antibodies. Those antibodies keep you immune for specifically for as long as they're in the blood. But when then they start to wane, when those antibodies start to go down, the memory B cells are there and they say, hey, don't worry about it. I'm going to pick up if you're exposed again, and I'll be there for you. Okay? So it's kind of like the idea is that if you make blueberry muffins every month and you got it down and you can make a blueberry muffin in 10-15 minutes, including baking time, I don't know how long it takes in an oven, but and if you got it down and you got that system down, and then you don't make blueberry muffins for a year, and then you come back and do it again, you're going to do it quick, and you'll remember how to do that because your memory B cells take over in your brain for blueberry muffins, B for blueberry in that instance. So, our immune systems work that way too. If they've seen something before and recognized it, they can rev themselves up very quickly and neutralize that virus before it has a chance to actually infect you. So is that going to be true for COVID? Well, there's no reason to think it wouldn't be because it's the way it works for all the other viruses. But we don't have specific data on it yet. It's going to take a while, and doing these studies where we measure antibody response and who gets in it again. So let's say that we do a study and everybody who's had COVID before doesn't get COVID again in the next 2 years, then we know that it works. Is there any proof that once someone gets the virus, they're immune and won't get it again? So Donna asked the question. I think I just kind of addressed that. So far, it looks like there is immunity, and it does look like it is protective. Is that true for 100% of people? Probably not. There's probably a handful of people that might get it afterwards, but I think it's true for the vast majority of people. As we just talked about, is a little bit of still a question, and we need to get some more time under our belt to know how long-lasting that immunity is. Right now, there's something interesting that happened in CDC guidelines a couple weeks ago that didn't really get picked up on the media, but is really kind of encouraging. So if you've had COVID and it's documented, and you tested positive, and you had symptoms and you tested positive, you actually get a 3-month don't need to quarantine card. And so what does that mean? It means that scientists and the CDC think that that immunity from that symptomatic COVID actually lasts for at least 3 months. And that means if you're exposed again, you don't need to quarantine. It also means you don't have to have a test if you need to go to get surgery. So I think that's encouraging. Hopefully that 3 months becomes 6 months, then becomes a year. We'll have to see as time goes on. I mean, we're only 5 months into this, right? So got some time yet to figure it out. Marcus asks, I've been seeing reports that COVID causes various types of long-term damage to the body, even in people with no underlying health issues. How accurate are these reports, and if accurate, is the damage permanent? Yeah, no, Marcus asks a good question because it is coming out that people who have recovered from COVID might have had some damage to certain organ systems. The ones that get listed the most are the lungs, because lung inflammation. So if you think about it, if you have a serious lung infection with inflammation, you get scarring afterwards. And so if you have scarring in an organ, it's going to reduce its function. And that there does seem to be, for people who've had more serious COVID in particular, those who've been hospitalized, particularly in an ICU setting, do have some lung function deterioration. There is also, COVID is associated with blood clots, particularly in the smaller vessels. And so if you get COVID and you've had blood clots go to certain places, then the tissue that's behind that blood clot doesn't get oxygen and nutrients for a while, and some of it can die. And that doesn't come back in some areas. So in the brain, for instance, if you've had a stroke related to blood clotting from COVID, that's going to be some probably permanent disability with it. I mean, the brain can heal itself to some extent, but it's seldom 100%. And then lastly, just this week, and I think this hit the media also, and published in JAMA Cardiology, where reports that the heart, there may be some lasting effects in some recovered individuals in the heart. And we don't know yet how permanent that is, because that was picked up on a registry study where it's people who've had COVID signed up to be studied after their COVID, you know, for the sake of science, even though they have no symptoms and they have no problems. And an imaging study of their hearts of some of these individuals showed some inflammation still weeks after all of their symptoms have resolved. What is that going to mean for them in a long time yet? I don't think we know. But it certainly is worth watching. And there's always been kind of a connection between heart disease and inflammation. And that's been studied for decades, and it might also apply to COVID. We'll have to see. And this is one thing I think that makes COVID as a virus different from a lot of other of our respiratory viruses. That while you can get permanent damage from flu, it's pretty darn unusual. And same with some other a lot of the other respiratory viruses. So COVID is a little bit more sneaky in that area. And then JD asks, how do you think this winter will be with COVID and the flu? Do you think cases will drastically rise? So we know that the virus that causes COVID likes colder temperatures, and we also know that it likes low humidity, so that's wintertime. We also know that people spend more time indoors in winter than in the summer. Although with as hot as it's been lately, maybe people are spending a lot of time indoors for their air conditioning now too. But generally, respiratory viruses are worse in the wintertime because of those reasons. And that's certainly true for flu. Will that be the case with COVID? I think so. You know, I think if there's a lot more people indoors, staying home, in close proximity, the virus is going to pick up and get transmitted easier. But the question that is different for now compared to our usual respiratory viral season is that this winter we're still going to be asked to be personally distancing and socially distancing. That's not going to go away for quite some time. And we will also, there's also a lot of schools that aren't going to reopen. And flu, for sure, gets transmitted with kids. As we talked about earlier, maybe COVID probably does some, but not nearly to the extent as flu. So if the schools are closed, there may not be as much flu going around. And then besides personally distancing and masking, what is that going to do for the transmission of other viruses? So if you look in my literature, the infectious disease literature, there's some ID docs say, wow, I'm really worried about this winter and COVID and the flu together. Then there's some ID docs that say, well, if everyone wears their mask and personally distances, probably both viruses won't be as big of a problem. And that's probably true too. So the devil's in the detail there. And frankly, right now, not everyone's masking and not everyone's personally distancing. And that's why COVID's still getting transmitted in places. So I think this fall, we're going to have to really be careful with that and going into the fall and winter. And I think if we can do that effectively, I think we're going to mitigate or push down that potential double whammy of flu and COVID together. But it's going to be up to us. It's going to be up to us as a society and as a community to do that. So I have some questions from Richard Craver at the Winston-Salem Journal that were also submitted. And so he says, Dr. Ohl, explain why it continues to take so long to get a COVID test through the process of getting tested or screened. And that remains a very good question. And frankly, it's a pretty simple answer. Too many people are needing to be tested, and there's not enough testing places or reagents to do it. So it's a supply and demand problem. Over the last month, 3 to 4 weeks, across the United States, we've had 5 states responsible for 60% of all of the new infections in the U.S. And these are California, Texas, Florida, Arizona, and I'll put Mississippi and Alabama and Georgia together. So it's that southern tier. What has happened in the U.S. over the last 20 years is that medical testing has been consolidated and brought into regional testing centers. And there's more efficiency with this. You set up one big lab rather than 1,000 little labs across every hospital. And so that means that, but that means that there's fewer places to get testing done. And frankly, when this system kind of developed over time, I don't think people were thinking about surge responses and pandemics for testing. And it just happens that a lot of these large companies that have now consolidated to do our testing just don't have the capacity to test for the surge that we're having now. And so, for instance, here, let's just take LabCorp, not to pick on LabCorp, because it's no different than for all of them. They're in Burlington, North Carolina, but they don't test just Burlington. They test also Texas, they test Florida. They're a regional testing center. And as we're part of that region means that these surges of cases occurring in these other states are slowing our test responses down too. So now the average turnaround time in these large contract labs runs between 5 to 10 days. The median, I think, is 7. There's also shortages of testing reagents. And so almost every hospital that I've talked to in North Carolina, and these include large academic medical centers, are on a day-to-day basis getting the reagents to run our tests and in our own labs. And now when I mean day-to-day means that when the box comes in the morning, we run our tests. And I mean, I can say so far so good. I don't think it's really affected turnaround time because, we've, with a little luck so far, have been able to keep up. But the reagent shortages have been a problem, and that's increased turnaround. So if you go down to hospital labs in Texas, for instance, those hospital labs they're having more trouble because they're trying to run a lot more tests. So that's why it's taking so long. And this creates problems, right? So if you want to effectively isolate and then quarantine contacts, you want your test back quick. You need it back. You would like to have it back in 24 hours. Once it gets beyond 72 hours, it kind of becomes, hey, is it even worth it anymore? Because by the time a person has had symptoms for 3 to 4 days and then gets tests, let's say it's a week later and their test result comes back, they're 10 days out, and you can already release somebody from isolation because 10 days is the isolation period now. So it's kind of like, wow, glad to know that's what I had. I'm glad I'm better. And so that's just not sufficient. So we really need to get this testing turnaround fixed. And we really need some national leadership to help us with this and with resources. And I'm not alone in saying this. Even Secretary Cohen in North Carolina said we need more federal help with this. And Once we get this fixed, then we can test and we can isolate and we can quarantine. And then it would make more sense to test contacts of people to known cases. Right now, you know, if you're a contact of a known case, it's like, well, go ahead and quarantine because, you know, the test isn't going to change what happens. You're going to quarantine anyway. So that's the answer to that. He also asks, and this is about CVS, so sorry CVS, I'm not picking just on that pharmacy, but other pharmacies who might be doing testing in other areas, so we're not singling them out. Are we worried about some of their tests showing up as false negatives? Not so much, no. I think their testing is like anyone doing tests. There are going to be some false negatives that occur for various reasons, but I'm really happy to have the help in testing from our pharmaceutical chains, and it's definitely been helpful increasing the number of tests that we can get done here in the Triad area in North Carolina. So thank you to CVS and Walgreens, and I'm not worried about their sensitivity personally. So those are Richard's questions. And unless there's any questions from the group?
I have a question.
Yeah.
What is your opinion on traveling to the higher case states like
Yeah.
Arizona or Mississippi, and do you have any advice for people that are traveling there?
Yeah, so what's my opinion about traveling to higher risk states? And we talked about this at length last week, and so people can go back and see what I said in my Facebook Live post last week. Make sure I'm saying the same thing this week. It's really not where you go as much, it's what you do when you go there. So if you go to Miami to visit your uncle, and you stay with your uncle, and you make the bubble, fuse your two bubbles, and you get takeout, and you order, and you personally distance when you go outside. If you go to the grocery store, you wear your mask, you hand sanitize, and you do all those things you need to do, even here in Winston, then it's probably a safe trip. But if you're going to go down to Miami for the purposes of going clubbing for a week, and hang out with your frat buddies, unmasked in a non-socially distant way, then that's pretty high risk. And that goes for even going to a lower risk state. So let's say you're going to visit South Dakota, which is kind of in the middle right now in the risk world. If you're not being careful about what you're doing, then it's just as bad as going to Florida. So it's what you do, not so much where you go. And if you find yourself having a lapse in judgment and you had a big night of clubbing, quarantine for 14 days afterwards and be a good citizen. So.
You talk about the regular flu, that will be coming up again, and you haven't. I guess you don't hear it in the news or hear anything about them prepping for the flu vaccine this year, because there's always a new strain and all that stuff.
Yeah.
What are the things that people getting that flu shot this year?
Right. So the flu shot this year. Good question. Thank you for answering about flu shots, because it is coming up on flu shot time. It's hard to believe. So one thing that's been interesting is that this year the Southern Hemisphere, which is winter, hasn't had nearly as much flu as they usually do. So, but we'll take it, right? Well, maybe that's a good sign. The flu vaccines have been developed based on the strain circulating last year. There's been there were a few changes in the vaccine makeup based on that strain that came up late last year that you remember caused kind of a resurgence. Right before COVID, we had a kind of a flu surge from a strain that had mutated a little bit. So that one's in this year's vaccine. All the vaccines this year, all of them will have 4 different influenza viruses that they'll protect you through. We always used to have 3, now it's all 4. 2 of them are A and 2 of them are B. And then The companies that are making them, looks like their production schedules are right on, and most of these are going to be available towards the middle or latter part of August. And this year, everyone needs to get a flu shot, right? Because if we can take away some of the problems from flu by everyone getting their flu shot, and I mean everyone, and let's not have any of this, I get the flu every year from the flu shot. No, you don't, because that's deader than a doornail virus. It can't give you the flu. Let's all do it this year so we can at least keep that under control as best we can. The other aspect of the flu shot is there's now 2 high-dose flu shots that are available for people over the age of 65, and if you're over the age of 65, you should inquire about the high-dose one, because it does work better for the elderly. So thank you for asking that question. Anything else? All right, well, we'll see you next week. I think we're going to solicit another round of questions and see how that goes, since we had such a great response this time.